1 second.
Okay.
Can you hear me and see the slides clearly?
I can hear and I can see the slides.
Okay. So, Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Thank you for being with us today for the 4th session. And I apologize for the last session where I was a little bit tired, so I couldn't make it. So, alhamdulillah, inshallah, today we will do it and we will compensate. So today we'll talk about another topic that is very important, and I think we encounter a lot of the cases that we will discuss today, which are the neurological emergencies. I had a comment before, a few days ago, that it's a little bit difficult to handle or to discuss the neurological emergencies. So I hope by the end of this session, this idea will be changed a little bit. Of course, taking this in theory and talking about something is different than practicing it and like having a case of a neurological emergency and dealing with it. Because most of the time, neurological emergencies are a little bit, the patient will be frightened, or the family or the parents will be anxious and frightened. And also this will be reflected on the doctor, and the doctor will be a little bit anxious. So one of the key things or the key points that we have to have like as a take-home message is, when you are encountering an emergency in general, always ask for help, not because you don't know how to manage. It is because having someone with you will make you a little bit calm, more calm, and better decisions will be taken. And also, if something will be forgotten for any reason, your colleague will help you in that. So specifically neurological emergencies, I think it's better and it's good to call for help and to ask a colleague to be with you while dealing with such a case. So when we talk about neurological emergencies, the things that we will discuss in our session are TIA and stroke, seizures, head trauma, loss of consciousness, and meningitis. The first topic we will talk about is TIA and stroke. And I'm sure most of you, if not all of you, have encountered a case of TIA or stroke in the clinic. So it is extremely important to know how to deal with such a case. So in general, the first thing we have to know is to know the difference between a TIA and a stroke, or a transient ischemic attack and a stroke. We have to know what are the symptoms the patient will present with in such situation. Most common symptoms are hemiplegia, or weakness in one side of the body, dysarthria or slurred speech, visual abnormalities, and those are what we call as typical symptoms. There are atypical symptoms of TIA and stroke, such as loss of consciousness, seizures, like focal seizure or generalized seizures. The patient may have like delirium, they have abnormal behavior, and all of these may be a picture or a presentation of a patient with a stroke or TIA. But the common things or the typical symptoms are the one that has been mentioned before, which are hemiplegia or weakness in one side of the body, dysarthria, and blurred vision. So the signs and examination findings, of course, this needs a neurological examination. And so we have to master the neurological examination and know how to do it and how to interpret the findings. And this is very important. I advise you just to look at the YouTube. Specifically, there are a lot of videos regarding examination, specifically neurological examination, from the book MacLeod, if you know it. You can find it in YouTube. Just write MacLeod, the neurological examination, and you will find how the neuro exam will be done in a proper, fast way. And I also advise you to practice it. Practice it on your patient, practice it on somebody at home just for practice on each other if you are having a study group or something. Approach to management, and that will be discussed inshallah in a while. What are the medication that we may consider, and what is the role of aspirin in TIA and stroke? The ABCD score, is it still valid, still used, or not anymore used? This will be discussed in a while. when to refer a TIA patient and how this patient should be referred. Should this patient be referred by ambulance, by car, directly right away, or within like 1 week or 2 weeks? All of these will be discussed in a while. So we will start with the scenario as always, as usually. So anyone can please read the scenario for me?
Okay, let me see. I'm Dr. Abdurrahman. Nadia is a 60 years old Kuwaiti lady known to have hypertension. Presented to the clinic complaining of facial weakness. Noticed in the morning while having her breakfast. It lasts for 60 minutes, then improved quickly. Blood pressure 140
So
over
قبل
90.
نقدر pressure دكتور من الهيستوري هذا what do you think?
Old lady, hypertensive, facial weakness in the morning.
دكتور عبد الرحمن لا تقول old عمرها 60 لا تقول old يزعلون بعدين. Okay, so she's an adult yeah. Okay,
she is an adult, well mature lady. Okay, hypertensive.
Yes.
have a facial weakness. بالشكل عام الفيتالز نورمال بس وحالتها حاليا cranial nerve examination currently is normal. So most likely to be a TIA.
Okay.
Brief symptoms resolved spontaneously. So should be as the TIA, the first differential diagnosis.
Okay, so I want to listen to your opinion. In this situation, if you have similar patient, I think the differential diagnosis will not be so wide. So أنت حطيت في بالك إنه number 1 a TIA, and I agree with you. So what's next? What you are going to do to this patient?
Refer to hospital. I will refer it.
Okay. When you refer this patient right away, emergency referral ولا شلون راح تبعثها?
Better to refer to emergency.
Okay. Are you going to refer this patient now, or you can give her and she can go whenever she wants?
I think better to be evaluated as soon as possible, because normally OPD clinics takes so much time and the patient may ignore the complaint.
Yes.
So better to be assisted in the emergency.
Excellent. So are you going to send her by car or by ambulance or by car
because this is vitally stable.
Okay. Okay, so are you going to give her anything before transferring this patient to the emergency room?
No, nothing.
Okay.
Nothing.
Okay, thank you very much, Dr. Abdurrahman. We will discuss now the thing. Okay. مشكور يعطيك العافية. Okay, so transient ischemic attack. I agree with Dr. Abdurrahman from the history that we have seen, and of course, because we are talking about transient ischemic attack, our mind now will go right away to as this patient is having a transient ischemic attack or TIA. So what is the definition of a TIA? Originally, or the original definition of the transient ischemic attack was time-based. كلنا نعرف لما يقولنا what's a transient ischemic attack احنا نقول a focal neurological deficit that lasts for 24 hours أو it occurs within the last 24 hours, not more than that. A sudden onset of focal neurological symptom and or sign lasting less than 24 hours brought on by a transient decrease in blood flow. However, this has now changed as it is recognized that even short period of ischemia can result in pathological changes in the brain or to the brain. So a new tissue-based definition is now used, which is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So this is the new definition of transient ischemic attack. So for us, is it going to make any difference clinically if the patient's presenting to us and the symptoms, neurological deficit, then it resolved and the patient came with no symptoms at all, and we took the history and we think now it's a transient ischemic attack? Is the definition will make any different or any change? Actually, no. So for us, there will be no difference regarding the diagnosis, whether the definition is the previous one, is within the 24 hours or the other definition, because also the 24 hours is still valid, number of hours to consider the transient ischemic attack. So what are the differential diagnoses that we should keep in mind whenever we are seeing a patient with a transient ischemic attack? المريض اللي مساعد, the previous history or the previous scenario that we have talked, we should keep always in mind some differential diagnoses. Some of the differential diagnoses that we may keep in mind as seizures, migraine aura, syncope, demyelination, metabolic reason like hypo or hyperglycemia, and head trauma. Of course, specifically المريضة اللي the previous scenario, which is hemiplegia أو يعني facial weakness in one side of the face. It's mainly the differential diagnosis will be like transient ischemic attack. We may think of facial palsy, which is it will not be acute and it will like resolve spontaneously. So those are things that we have to keep in mind also. So how we are going to assess such a patient? Of course, after taking proper history and doing examination, we have to assess this patient, what's the prognosis of the patient. So there was an old prognostic score, which is the ABCD2 prognostic score, which is a risk stratified patient who presented with a suspected TIA. Previously, it was used. Why is that? Because according to the ABCD score before, we will decide that they are going to refer now or we will refer urgently within 2 weeks. And because if the ABCD score is high, it means that this patient is prone to another TIA within in the upcoming few weeks. But according to NICE guidelines, it is not anymore used. However, data from studies have suggested it performs poorly and it is therefore no longer recommended by NICE clinical knowledge summaries. But if you look at up to date, it is mentioned there. But again, it's not something to rely on and to depend on in the assessment of a TIA. New recommendation, instead, NICE recommend that immediate antithrombotic therapy by giving aspirin 300 milligram immediately should be recommended in case of a transient ischemic attack, unless the patient has a bleeding disorder or is taking an anticoagulant, which this needs immediate admission for imaging to exclude a hemorrhage. The patient is already taking low-dose aspirin regularly, so the patient should continue on the same dose that he's taking and until reviewed by the specialist, or aspirin is contraindication for any reason. So those are the 3 situations where it is not recommended to give the 300 milligram aspirin if the patient is coming with a transient ischemic attack. We have to keep something in mind. As we said, that if the patient presenting to us in the clinic and there are no symptoms at all, the patient is completely normal, no neurological deficit whatsoever, but he or she said that in the morning or 1 hour ago or 2 hours ago or 1 day or 1 week ago, I had such and such neurological deficit, and you took a proper history and you have decided that this patient is mainly what he had or what she had was a transient ischemic attack. In this situation, we should give the aspirin unless it is contraindicated for these 3 reasons. But if the patient presented and he's having now a neurological deficit, we don't know, is it like a transient ischemic attack? Is it going to resolve within 1 hour or within a few minutes? Or this is a stroke, this is going to continue, or this is going to be like a stroke that has to be investigated. And if we are not sure and the patient is presenting now with neurological deficit, we will consider this as a stroke until proven otherwise. أعيدها مرة ثانية. يعني المريض وصل عندنا بالعيادة وما عنده أي neurological deficit، بس قال لنا كان عندي neurological deficit من ساعة، نص ساعة، ساعتين، 3 ساعات، whatever. فإذا this is a transient ischemic attack, I will give the 300 milligram of aspirin unless it is contraindicated. الحالة الثانية يعني المريض الحين عنده neurological deficit, whether hemiplegia, whether weakness in one hand and lower limb and upper limb, dysarthria, weakness in the face, or any of these. الحين هو موجود عنده symptoms. So I don't know, يمكن هو بعد نص ساعة تروح. هو يعني very early. إحنا عندنا very early access to the clinic. فهو الحين حسب الأعراض و right away he came and he's still having the symptoms. This patient will be considered as a stroke. حتى لو راح المستشفى and the symptoms resolved spontaneously and they diagnosed him there as a TIA, ما لنا شغل. إحنا شفناه بالneurological deficit فإحنا نقول إن this is a stroke and we will not give aspirin. I hope that this point is clear. If it's not clear, please let me know at the end of the session. Okay. So if the patient has had a suspected TIA in the last 7 days, now, so we decided that this is a TIA and we decided that we will give this patient 300 milligram of aspirin. وخلاص عطيناه الأسبرين. So now we will think of the decision of transferring the patient. هل أنا لازم أحوله الحين? Should I refer this patient now? Should I refer him urgently? Should I refer him by car or by ambulance? So those are some guidelines from NICE that may direct us to what we can do. طبعا احنا لازم نفكر ان احنا we have to read the guidelines, we have to know the guidelines, we have to understand the guidelines, but we have to like يعني tailor to reality. So if the patient has had a suspected TIA in the last 7 days, اليوم أمس اللي قبله within 7 days he had the TIA, this patient should be assessed by stroke specialist and referred to emergency to be seen by stroke specialist within 24 hours. لازم يروح. Again ليش قلت لكم we will tailor this to our reality؟ لأن in fact إحنا نفس ما قال الدكتور أنا ما أضمن يروح. Maybe this patient will ignore the symptoms. Maybe he will just postpone the transfer. It's better to refer the patient now to the emergency room. Why? Because this patient may get another TIA at any time. If the patient has had a suspected TIA which occurred more than a week previously, يعني قبل الأسبوع صار عنده إيانة وقال عندي symptoms كذي and we suspected that this was a TIA, we have to refer for a specialist as soon as possible, and it was يعني recommended that it should be within 7 days. Okay, so إذا كانت قبل الأسبوع within 7 days this patient should be seen by a specialist, a stroke specialist. Of course, again we will tailor this to our real life. You can do both. You can either refer this patient لو كان عندكم proper access, proper referral criteria, proper referral procedure وآلية واضحة للتحويل, so you can write the referral and write down that this occurs in the specific time. This patient should be seen within 7 days according to guidelines, so for your kind care by stroke specialist. فإذا أنتم متأكدين إن هذا راح يتحول within 7 days, well and good. Otherwise, to be safe, refer this patient to the emergency room. Okay? So advise the person not to drive until they have been seen by the specialist. So regarding السؤال اللي سألته الدكتور عبد الرحمن, هل are you going to refer this patient by car? It is better to avoid driving, and it is recommended to advise to avoid driving because again we never know when another TIA may develop. So it's the right thing is to transfer the patient either by ambulance, or if he is vitally stable and he's fine and you are sure that this patient will go to the emergency room, they can go accompanied by somebody, but they are not the one who are driving. Okay. Okay, this is regarding TIA. I need someone please to read this scenario for me.
السلام عليكم.
عليكم السلام. هلا دكتورة. هيا إن شاء الله تفضل.
Samira is a 33-year-old lady, previously healthy, presented with right-sided upper and lower limb weakness since a few hours. Medications, oral contraceptive pills, blood pressure 160/100, oxygen saturation 98, pulse 100, respiratory rate 15.
Yes. إيش رأيك دكتورة? What do you think?
She has hypertension. So, otherwise, taking OCV, maybe she is more has a chance to develop thromboembolic disease.
Yes.
And maybe this is a stroke.
Yeah.
Mostly weakness.
I agree with you. So I'm intendedly I added this scenario just to make you feel like think wider, look to the bigger picture. تينا مريضة sometimes 33 years old, coming with right-sided upper and lower limb weakness since few hours and continuously having the same symptoms. So of course the history of medication, which is the oral contraceptive pills, some ladies will not offer telling you that they are on a contraceptive pills because they think that this is something normal. It is okay, I'm taking it, it's for birth control. What does it have to do with any other problem? So it is very important to ask about the risk factors of a stroke, especially if you are having a young person. So a 33-year-old, for me, if I will have a patient with hemiplegia or weakness in any side of the body, or any numbness or paresthesia, I would think of one of them is a stroke, one of the differential diagnoses, especially if there is a risk factors such as medications that may induce stroke, like most common one is contraceptive pills. The other one is, I would think of demyelination or demyelinating disease, as the person is young. Maybe I will think of antiphospholipid syndromes or any medical problem that will increase the risk of thromboembolism and strokes. So just I'm adding this. I'm not giving you the typical symptom of an old lady or old gentleman who are presenting with hemiplegia because they are diabetic, hypertensive, ischemic heart disease. They have like multiple comorbidities. No, we may have previously healthy people coming to us. They are young with neurological deficit. So just keep in mind to put the risk factors and the differential diagnosis that you may think of in such a case. Okay, so please don't ignore medications. Always ask about medication in case of most of the patients, if not all of the patients, because there are a lot of medications that are over the counter. Some patients are not considering them as a medicine that they have to talk about. In real life, sometimes you tell the patient if you have any medical problem, they told you no, and in the system they are diabetic and hypertensive, and they don't consider this as a medical problem. I don't know why, because maybe they're used to it, or I don't know why. So it's good to ask specifically. General questions and open-ended questions are good, but closed-ended questions, specific questions about certain medication are very important. So we are talking now about stroke. So there are situations that we should keep in mind in case of stroke. One of them is hypertension. If the patient presented with high blood pressure and they are having a stroke or symptoms of neurological deficit suggestive of stroke, just be sure that you should not reduce the blood pressure fast. The reduction of blood pressure should be by 15% during the first 24 hours after a stroke onset. So just keep in mind, it's not our job to reduce the blood pressure in the clinic. Our job is to diagnose, to detect, to do the initial management, stabilize, and send the patient where they will reduce his or her blood pressure gradually over 24 hours. Sometimes in case of a stroke or TIA, we should think of arrhythmia as one of the reasons for stroke. If the heart is like having atrial fibrillation or any type of arrhythmia that's causing showering of strokes from the heart to the brain. If she's a female, let's think of oral contraceptive pills or any other medications that may precipitate, or hormone replacement therapy, for example, in case of an elderly lady, where they will be the risk factor or the reason for this stroke. Okay, in stroke, we have a stroke assessment tool that we may use, and it may help us in confirming the diagnosis, which is the Rosier score. In this Rosier score, any number above 0 will be considered as a stroke. Loss of consciousness or syncope, this is it is like atypical symptom of stroke, so it will be considered as a -1. A -1 point. Seizure activity also, they are atypical, and it is a -1. But a new or acute onset of asymmetrical facial weakness, this is a +1. Asymmetrical arm weakness, this is a +1. Asymmetrical leg weakness, this is a +1. Speech disturbances, +1, and visual field defect, this is a +1. So if any one of these is like positive, then most probably we are dealing with a stroke. So this is like a summary of what we have done or what we have mentioned before. It is a different, this is how we are going to deal with the stroke versus a transient ischemic attack. So in stroke, we have to call the ambulance, we have to check the ABCDE, vital signs, saturation, we should keep vein open, restrict IV fluid, specifically if the blood pressure is high, and we should not give aspirin. So this is the key point here, we should not give aspirin in a stroke. If the patient is having now a neurological deficit, aspirin should not be given because it may be a hemorrhagic stroke and we may deteriorate and increase morbidity and mortality. In the case of a transient ischemic attack, the patient now is fine, but he had a neurological deficit either within 1 week or more than 1 week. So if it is within the last 1 week, we will call ambulance. If it's stable and symptom-free now, can send by car, accompanied by someone, not driving. have to refer and give, before referral, we should give aspirin 300 milligram unless it is, if the patient has bleeding disorder, patient is on anticoagulation, aspirin is contraindicated, or there were more than one TIA. I tried to search for the reason why more than one TIA can be a contraindication of giving aspirin in case of transient ischemic attack. What I found that if there is more than one TIA, this patient is prone to have thrombolysis, and aspirin may affect thrombolysis, so it's better to avoid giving aspirin. If more than 7 days, refer to OPD within 7 days. And as we mentioned before, if we are not sure that the patient will go, or we are not sure about the procedure or آلية التحويل and the procedure of referral, and we are not sure that he will be seen within 7 days, it's better to refer for emergency. And this is the Rosier score that has been mentioned previously. This is regarding TIA and stroke. So we will talk about another topic, and I need someone to please help me in reading this scenario. Oops.
This is Dr. Saima.
Yes, Dr. Saima.
Hamad is 3 years old child brought by his scared parents to the clinic due to the convulsion that started 3 minutes ago and is still not aborted.
Yes.
The oxygen saturation is 91.
Hello?
Yes, doctor.
Yeah, doctor. Yeah.
And pulse is 100 per minute. Respiratory rate is 16. And temperature is 38.5. RBS is 6.5 millimole.
Yes. Okay. What do you think, doctor?
I think because the temperature is 38.5, so it could be febrile convulsion.
Okay. So what you are going to do in this situation?
First, I will call the ambulance.
Okay.
And then I will go for check for ABCDE, temperature, and the sugar, I guess.
Yeah.
And
Sugar is already checked, temperature is already checked. So what's next?
I will put the patient in a recovery position.
Excellent. Yes.
And because the oxygen saturation is low, 91, so
Yeah.
I will give oxygen.
Very good. Okay.
And then I will give diazepam.
Okay.
Rectally, per rectal, 5 mg, I guess.
Okay.
And then I will wait for the seizures to, aborted.
Okay. Okay, excellent. So if the seizure is aborted and the child is fine and he was a little bit drowsy, which is expected after a seizure, so are you going to do anything else later on?
I will repeat the diazepam again after 15 minutes.
No, the child is fine. The seizure is aborted. Yeah, and the child is a little bit drowsy after the seizure and after the diazepam, which is expected, right?
Yeah.
Yeah. So anything else you want to do?
I will, because the child is under 3 years old, I might send for the assessment. I will send the patient to the secondary care for further investigation or something.
Okay. Is it the age that give us leads us to the decision of transferring the patient or not to transfer the patient, or something else?
I think it's not urgent to send the patient to the secondary care. I think it's 3 years, could be febrile convulsion.
It is mainly febrile convulsion. The child is febrile and he has a convulsion. I would let's say if it was a generalized tonic-clonic, that will also help us more. But what is the key point, or how we can take our decision that we have to transfer the patient or not to transfer the patient? What about if this was the first time?
Yeah.
First attack. If it is a first attack, or there is a history of recurrent attacks, if he's in previous convulsions or not.
Okay. In the same illness, he had multiple attacks, we have to refer. In the clinic, it was not aborted after 2 times of diazepam, we have to refer. If it is the first time, we have to refer. So on those three things or three situations, we have to refer the patient. But in general, sometimes because of the anxious parents and the child will be like drowsy and all of these, and we already called the ambulance from the beginning and the ambulance arrived, and it's okay to refer the patient to emergency room and they can discharge her or him from there. But if the seizure aborted, this is not the first time, the child is fine now, the family are fine with it, and they know how to deal with it, we will do counseling for the patients, for the parents, of how to deal with a seizure later on, if it developed again, and if it happens in the same illness, they have to come back to us where we have to refer them to emergency room, or they can go to the emergency room right away. So those are the things that we have to keep in mind. So let's talk about convulsions. So we have to keep in mind the symptoms, and specifically if the patient is conscious or unconscious, it means it is generalized or focal convulsion. We have to think of the approach to management. What are the medications that we should keep in mind? So this is like an algorithm, a summary of how we are going to deal with a convulsion. So we have to call ambulance, as Dr. Saima said. We have to check the ABCDE, we have to check temperature and blood sugar. In the scenario, I have offered you the information, but in real life, you have to ask for those and order it and ask the nurse to just give you the results of the temperature and the blood sugar. Because maybe the reason for the convulsion is hypoglycemia or hyperglycemia, so we have to keep in mind that we have to check the sugar. We have to put the patient in recovery position, as Dr. Saima mentioned, and we have to give oxygen, especially if the oxygen saturation is lower than normal. If the fit does not stop after 5 minutes spontaneously, we have to give diazepam rectally by the proper dose to the age of the patient. Of course, I have mentioned this previously, and sometimes we are saying, how can we assess this 5 minutes? Just keep in mind that even the nearest house to the clinic, the patient may come like walking. With the scary environment and what happened, and after they just take the child and bring him here, maybe 3 or 4 minutes will be passed as they run to the emergency room and putting the patient in the room, and all of this checking what's happened. I think the 5 minutes has been reached. So mostly, once you see the child, mostly, let's say, I will not say 100%, but most of the time, almost always, the 5 minutes will be passed. So you will start treatment, unless the seizure started in your clinic. So the child was fine and he starts seizing, where you have to calculate the 5 minutes. The 5 minutes is important for the family, where we can ask them, especially if this is happening recurrently, we can advise them to wait, to keep the child in his lateral position, and we will ask the patient the parents or the family, the caregiver, to stop until 5 minutes before giving the rectal diazepam, because the seizure may abort by itself. So in the clinic, in our setting, in primary care setting, mainly if we see the child, the 5 minutes will be already passed, so we will start treatment immediately. There is one point that we should keep in mind, that if we have a diazepam and we have a paracetamol, and the child is having fever now and seizure at the same time, what we are going to give first, the diazepam or the paracetamol, suppository? So someone can answer the question for me?
I believe diazepam is priority here.
Yes, you are right, doctor. Diazepam is a priority. So febrile seizure, even if the child is febrile and he's having seizure, and you have both diazepam and paracetamol, the priority is for the diazepam, not for the paracetamol. Okay. So if it is status epilepticus, what does it mean by status epilepticus? Either having attack, then subsided, then another attack of seizure, or it is continuously more than 30 minutes. This is status epilepticus. We can repeat the same dose every 15 minutes until ambulance arrive. A lot of discussion has been done with a pediatrician once about how can we assess. Sometimes the ambulance will have a delay, so we will not have the ambulance fast within, if we gave once and we repeat after 15 minutes, and it's 15 minutes has passed and we want to give another dose of diazepam, can we give it or not? The recommendation is not to give more than 3 times, but sometimes we have to weigh risk and benefits. Are we going to keep the child seizing until the ambulance arrive, or we can give another dose of diazepam, or at least a lower dose of diazepam? Of course, we are afraid of respiratory depression and the other complications of diazepam, but always we have to weigh risk and benefit and the whole situation. And we all know that our resources are so limited. Okay. So special situation, febrile convulsion and antibiotic, as we mentioned, the diazepam will be prioritized. If it is first attack or recurrent attack, if it is first attack, this is ensuring referral. While recurrent attack, in certain situation, we may be fine to send the patient back home. Status epilepticus, always refer the patient, repeat diazepam not more than 3 times if possible. Non-epileptic, non-febrile convulsions like carbohydrate spasm, extrapyramidal side effect should be considered, especially if the seizure is not so typical, not so generalized tonic-clonic. And we will discuss in a while how we're going to manage such cases. So extrapyramidal side effect dystonia, it's usually a side effect of medication. What are the most common medications that may cause extrapyramidal side effect? I think all of you know one of them is something that we always use in our clinic, or we use a lot, which is the metoclopramide. And another medication that may cause extrapyramidal side effects are the antipsychotics, especially the old antipsychotics, not the new ones. So we have to keep, although we don't prescribe it, we don't give it to patients, but sometimes some of the patients will be already on the antipsychotics and will come to us with extrapyramidal side effects. So keep it in mind. So what is the treatment for extrapyramidal side effects? There are 3 categories of medications that we may keep in mind. One is anticholinergic. I don't think we have it in the clinic. Examples are bizotropine, or called cogentine, procyclidine or camedrine. Those are the 2 types of anticholinergics. Most patients respond within 5 minutes and are symptom-free by 15 minutes of giving them those medications. Another type of medication that may be used for extrapyramidal side effects is the antihistamine, like diphenhydramine, 1 to 2 milligram per kg, up to 100 milligram by slow intravenous injection. The third type, which is also present in most of the clinics, which is promethazine, the Phenergan. The dose is 25 to 50 milligram intravenously or intramuscularly. And the last medication that we may give in case of extrapyramidal side effect is the diazepam by a dose of 5 to 10 milligram intravenously. I have seen like 3 patients that had extrapyramidal side effects in my whole time of working within the last 10 years. One of them, I saw her in the emergency room. She went to the clinic and she was having gastroenteritis. She was prescribed metoclopramide. She took 3 doses or maybe 4 doses, and she started to have the dystonia and the stiffness of the neck and the stiffness of the hand. And she came by ambulance. We saw the patient. We asked like a few questions. We found that she was on metoclopramide, and she took it for a few days. We gave her right away diazepam, and like within a few minutes, she was completely normal, fine, and she was discharged home like within 30 minutes. Also, I saw another patient in the clinic, and she came in the morning. She took through two doses of metoclopramide, and she developed the same problem. We were reassuring the patient, but she was hyperventilating and she was afraid, and we were like afraid that she will go into more stiffness and more tiredness and more symptoms, and she may go with the extrapyramidal side effects into carbohydrate spasm. So carbohydrate spasm, usually it happens due to hyperventilation. The patient, and I saw a patient today, in fact, she didn't reach the carbohydrate spasm, but she was about to reach it until, alhamdulillah, we have managed her with good reassurance. She had palpitation, and due to like, she was taking paracetamol extra from private, over the counter, and she took some caffeine, caffeinated drinks. She started to have palpitation. She's a little bit an anxious personality. So after having this palpitation, she felt afraid, and she started hyperventilating. She came to us with numbness all over her body and all over her mouth, And I think if she was not treated by reassurance initially, she may develop the carbohydrate spasm later on, because also I have seen one patient with carbohydrate spasm due to hyperventilation before. So it occurs when acute hypercapnia causes reduced ionized calcium and phosphate levels, involuntary contractions of the feet, or more commonly the hands. There are certain signs that we may do and test to confirm the diagnosis, like Jovostic and Trozius sign. They may be positive because of hyperventilation that induced hypocalcemia. So hyperventilation will induce hypocalcemia and hypercapnia. The CO2 will be raised, the calcium will be low, so the patient may have the numbness and the positive 2 signs. Wheezing may be heard because of bronchospasm from hypocarbia. The management before, the advice was rebreathing into a paper bag, which is no longer recommended because significant hypoxia and death have been reported. Once life-threatening conditions are eliminated, simple reassurance and explanation of how hyperventilation reduces the patient's symptoms are usually sufficient to terminate the episode. And that's what happened today in front of our eyes. The patient was having numbness, she cannot talk, her heart rate increased even more. And after reassurance and explanation, I explained to her exactly that she should breathe slowly because her hyperventilation may make her symptoms worse. And I tried to talk to her. Then she felt better, she calmed down, she started giving me history. Her heart rate becomes from 140 or 135, it becomes 100, and she was feeling better, alhamdulillah. So regarding other modalities of treatment, benzodiazepines for stress relief and for resting, the trigger for hyperventilation, is effective, but patients may require prolonged treatment. So we have to dig more in the history later on. If the patient's having anxiety, having phobias, having panic attacks, those problems should be treated properly. So although acute chemical sedation may be effective and humane, because we will not keep the patient like stiff and like frightened and scared and just look at this patient. So it is humane to give some things to the patient in selected severe cases, but prolonged use of these medications should not be initiated in the emergency room or the primary care settings. Stress reduction therapy, administration of beta blockers sometimes, breathing retraining have all proven effective over the long term. So this is regarding extrapyramidal side effects and carbohydrate spasm. So I have
عندي دكتور سؤال بس.
تفضل.
الكاربوبيدال يعني عادي اذا اعطيته دايزيبام صراحه الحالات هي يعني عادي ما في مشكله.
You can, yes.
Okay.
So scenario number 4, can somebody read it, please? يلا حد يبي يقرأ؟ تفضل.
Mariam is 80 years old, known to have hypertension, diabetes, ischemic heart disease, and atrial fibrillation brought by her son after a fall while she was walking at home. There was a bruise around her left eye and pain in the left shoulder. Okay. Medication, glucophage, insulin, Diovant, normine, warfarin. Blood pressure is fine, pulse is fine, respiratory rate is fine, skin is fine, neurological exam is normal.
Okay. So we have a history of fall and head trauma. صح دكتور؟
تمام.
Okay.
Head trauma, syncope for investigation. There's many causes she might have.
It wasn't syncope, doctor. She fell down. She slipped by the carpet.
Oh, okay. Sorry. Brought by her son after a fall while she was walking.
Yeah.
Not
walking, slipped by a carpet and she fell down. The result was she's having bluish discoloration or bruise around her eye and shoulder pain. And she's 8 years old. Diabetic, hypertensive, heart disease, AF. What you are going to do to this lady?
Fall, I need the sugar. How much is the sugar? So
sugar was normal.
Sugar
not
is normal.
Type, yeah.
what is the next step to do, yani?
Yes.
We'll have to make an X-ray for her around her left shoulder and for the skull.
Okay.
And
So what type of X-ray? X-ray, regular X-ray you will do for the skull?
CTI.
CT.
yes, regular for the left shoulder.
Okay.
And around her eye,
agree.
maybe. And maybe we can do CT because she's having atrial fibrillation.
Yes. And she's on warfarin, right?
On warfarin.
And also there is a sign which is the bruise around her left eye, what we call it. Have you ever heard about the raccoon eye?
Yes, but this is because of the fall or spontaneous bruising.
It's after the
because
fall.
of the fall?
We don't know. It's after the fall.
Okay.
It happens after the fall. Yeah.
هذا بيبقى تبع كسر قاعدة الجمجمة بس أنا مش
Yeah.
فاكر شو اسمه تبع.
Yes.
يبقى في nasal cerebral fluid. Yeah.
Yeah. So you
should get
agree
checked.
that this patient deserved referral for a CT scan of the head, right?
Yes, of course.
Yes. Okay. So let's talk about this subject or this topic, which is head trauma. Of course, any trauma of the body we have. I will give you now at the end of this few slides. We will have like a summary of how we are going to approach a patient with a trauma in general. And then, but we will talk now, because we are talking about neurological emergencies, we'll talk about head trauma specifically. So if the patient presented to us with head trauma, we have to see how he is presenting, stable or unstable, conscious or unconscious. We will assess the ABCDE, we will assess the Glasgow Coma Scale. If he's conscious, oriented, and he's fine, we will start taking history about the mechanism of the fall, how it happened, or the trauma. It's not necessarily a fall. It could be a trauma, an RTA, like any type of trauma. We will look for any signs and examination findings, like as we said, the redness, I mean the bruise around the eye, any secretions or any CSF secretions from the ear or the nose, and we will talk about the other signs, and we will think of the management now. So there are certain things that we should keep in mind. If there is any bleeding, if there is any cut wounds, there is any like this patient is in severe pain, they need painkillers, there is like a suspicion of a fracture, we need to do fixation, stabilization of the limb, we may need neck collar, do we have to give IV fluid because the patient is bleeding, for example, do we need to do dressing for the scars or the cut wounds that we have? Do we have to use the tetanus toxoid if the patient is having an RTA or he felt like on the floor or something? So all of these should be considered. And there are special situations that we should keep in mind. The head trauma, when to refer a head trauma and why to refer this patient. Then bleeding, if there's any bleeding, and if there is any medical legal issue behind this trauma that the patient is presenting to us with. Is it abuse? There's a domestic abuse. It is an RTA that we need the police report, for example, for it. Do we need to include the police? Do we need to include, like, we have to do a report? We have to do anything? All of these should be mentioned and kept in mind. Is it a fight, for example, and the trauma happened after a fight? So all of these should be considered and should be mentioned in the referral letter if we are going to write a referral for the emergency room. When to refer a patient with head trauma in adults, NICE has a strict, just before discussing those things, I have heard a case from one colleague who said, I had a patient who presented to the emergency, to the clinic, and was referred to the emergency without writing anything on the referral. They wrote just only that there was head trauma, and they sent this patient to the emergency. The patient reached the emergency, and he was fine. He was conscious, oriented. Everything was fine. They measured the vital signs, and all the vital signs were normal. A little bit of high blood pressure, maybe because the patient was scared for the head trauma. The doctor see the patient. He asked him briefly what happened. He said, I had an accident. I don't know for what reason the doctor did not take a proper history, but they kept the patient for a while. After a while, the doctor came back to the patient and he discharged this patient since all the vital signs are normal and the emergency room was so crowded. The patient left, but the phone numbers and everything was there. After a while, another patient came. She came because she had she said that there was a road traffic accident and she hit somebody by car. What happened that it was found that this patient, the female patient, the accident was a pedestrian accident for the other gentleman that has been discharged because his vital signs were stable. But unfortunately, he deteriorates later on. So why I'm telling you this history? Because you are the first person who are seeing this patient. It is very important to take history, and it's very important to document this history to the emergency room for the doctor, because maybe the doctor is having like a so crowded emergency room. I know this is not an excuse. Maybe they will not have time to take the mechanism of the trauma or the fall or whatever properly. So if we can do this, it's better to do it. And I always tell my resident, imagine that you are the only doctor that you will see this patient. You imagine that you are the only doctor that will take history. You are the only doctor that will manage it properly. So do your job to the maximum, because you may help lives, or save lives with what you are doing. So don't underestimate writing proper history in the emergency referral. I know sometimes it's like busy clinic, sometimes you have a lot of patients waiting, but I think everything can wait because this is an emergency and it's worth having extra time on an emergency instead of giving sick leaves for other patients waiting in the waiting area. I think all of you agree. So let's go back to our head trauma. NICE has a strict and clear guidance regarding which adult patient are safe to discharge and which head needs further CT head imaging. The latter group has also divided into people that need CT now, right away, immediately, and those who need CT within 8 hours. Again, let's tailor those guidelines to our real life or to reality. For us, if we are seeing a patient with head trauma and with the things that we will mention in a while, we will refer right away. We will not wait for the 8 minutes because it's sometimes hard to detect. So CT head immediately should be done for any patient with a Glasgow Coma scale less than 13 on initial assessment, Glasgow Coma scale below 15 at 2 hours post-injury suspected open or decreased skull fracture, any sign of basal skull fracture like hemotympanoid, panda eyes, cerebrospinal fluid leakage from the ear or nose, battle sign, post-traumatic seizure, focal neurological deficit, more than one episode of vomiting. In those situations, we should refer the patient. They should do a CT now. We're talking about adults now. So who needs CT within 8 hours of the head injury? Again, in our reality, we will refer the patient. They will decide for how long they will keep the patient before doing the CT. But for us, the patient presented to us with one of the following, we will refer right away. So adult with any of the following risk factors who have experienced some loss of consciousness or amnesia since injury, and the age was 65 years or above, and the patient is having a history of bleeding or clotting disorder, dangerous mechanism of injury like pedestrian or cyclist struck by the motor vehicle, an occupant ejected from the motor vehicle, or a fall from a height of greater than 1 meter or 5 stairs, we have to refer for CT. More than 30 minutes, retrograde amnesia of event immediately before the head injury, we have to refer. Any patient who is having an anticoagulant or on warfarin, we have to refer for CT head within 8 hours. In general, for us, if the patient, those are the things that we have to ask about. We have to assess the Glasgow Coma scale, conscious level. We have to ask about medications such as anticoagulant medication. We have to ask about any bleeding disorders or clotting disorders. We have to ask about the mechanism of the injury. If it is serious, we have to refer. Fall from height from 1 meter or 5 stairs, we have to refer for CT. Previous slide, any Glasgow Coma scale below 13, any below 15 within 2 hours, any amnesia, any seizure, any more than one attack of vomiting or neurological deficit, all of those patients should be referred for, or any signs of basal skull fracture, as the lady that we have talked about, we have to refer for CT scan to be done. They are the one who decided this CT should be done now, right away, or we will wait for a few hours before doing the CT scan. Regarding children with head trauma, which is something also common, And I have seen a lot of very scared parents who are bringing their children because of head trauma. The thing is with children, usually most, because the CT scan is like a lot of radiation for a child, so they have this from up to date, this categorization of pediatrics age group coming with head trauma in order to assess, do we need to do a CT right away, or we have to observe the patient before doing a CT, which we may not need to do a CT. So when you look at it together, any one of the following: Glasgow Coma scale below 14, other altered mental status, palpable skull fracture, signs of basilar skull fracture similar to the previously mentioned, post-traumatic seizure, bulging fontanelle, concerns for abuse, all of these, they are high risk and they need to perform neuroimaging for them. Children above 2 years with a Glasgow Coma scale of 15 and one or more of the following: history of loss of consciousness, history of vomiting, severe mechanism of injury, or severe headache. These are intermediate risk patients, and we have to observe for 4 to 6 hours before doing the imaging. For infants who are having a Glasgow Coma scale 15 and more, less than 15 and one or more of the following: loss of consciousness more than 5 seconds, severe mechanism of injury, occipital, parietal, or temporal scalp hematoma, not acting normally per routine caregivers, history of lethargy or irritability, now resolved age less than 3 months, with non-trivial trauma or vomiting. This is also we have to refer for observation. The low-risk patient are absence of any of the above risk factors and age above 3 months, and there is any one of the things that we have mentioned. We do not need to perform a neuroimaging, and we can discharge home with anticipatory guidance and safety netting. So this is a summary of the trauma in general. So whenever you have a patient with trauma, you have to assess: is the patient conscious? The Glasgow Coma scale is like conscious, the patient is oriented. The Glasgow Coma scale is 15/15. The patient is hemodynamically stable. Then in this case, we have to assess the need for painkiller. If suspected fracture, we have to stabilize and refer for orthopedic surgeon. If there's a cut wound and there's mild bleeding, we can do dressing, give IV fluid, refer to surgical emergency. On the other hand, if the patient is unconscious with a Glasgow Coma scale less than, can you give me a minute, please? Okay, sorry for that. So we have to, in case of the patient is unconscious or the Glasgow Coma scale is below 14 or 14 and below, and the patient is unstable, there is a bleeding, there is head injury, we have to insert 2 large bore cannulas, start IV fluids. If there's a fracture, stabilize and refer to general hospital, surgical emergencies. The patient is unstable, so we will not refer, even if there's a fracture, we will not refer to orthopedics emergency. We will refer to general hospital where they will get the orthopedic surgeon there. And those are the 2 boxes where are the indications for referral for CT scan. All of them has been mentioned previously, but here they are summarized from 1 to 9 in pediatrics and from 1 to 11 in adults. So the last, the topic before the last, which is loss of consciousness assessment, which is another topic or another situation that we may encounter in a case of, as a case of emergency. So in case of loss of consciousness, we have to assess the patient. Of course, we have to call ambulance. We have to put the patient on the recovery position. Unless history of possible spinal injuries there, we have to keep the patient as he or she is and put neck stabilization. We have to check the ABCDE score assessment. We have to check the Glasgow Coma scale, or what we call the 4 score, which is a score to assess the eye, motor, brainstem, reflexes, and respiration. We have to check the pupillary light reflex. And there are 2 things that we may find when we examine the pupillary reflex. One of them is a constricted pupil, and the other one is dilated pupil. Of course, those signs may give us a hint of the substance or the material or the a medication or whatever the patient was on, and is the reason for the loss of consciousness. So if the eye is the pupils are constricted, we have to think of opioid overdose or cholinergic medications. If the pupil is dilated, we may think of cocaine, amphetamines, caffeine, tricyclic antidepressant. طبعا caffeine, it doesn't mean coffee and tea unless the patient drank a lot of coffee and tea, but we may think of the energy drinks, which are caffeinated, like very, very highly caffeinated drinks. We think of tricyclic antidepressants, antihistamines, benzodiazepines, barbiturates, alcohol toxicity, and SSRIs. All of them in an overdose may cause dilatation of the pupil. So we have to check the random blood sugar in an unconscious patient because this patient may have a hypo or hyperglycemia. We have to reassess regularly, and we have to reassess the ABCDE. We have to reassess the Glasgow Coma Scale regularly, and then we have to obtain additional information, if possible, from the witness, from attendant. We have to check the medical notes from the system, any past medications that has been prescribed, and they may be the reason for the loss of consciousness. We have to ask about any clues from the scene, any suicidal notes, any use of needles, any drug injections, equipment. All of these may help us to know the reason for the loss of consciousness. This is a reminder of the ABCD assessment, as all of you know, and this is also a reminder of the Glasgow Coma Scale. Loss of consciousness management, we have to insert an airway if required, and if you are competent to do so, and it's good to be competent in such a situation. Again, IV access, 2 large bore cannulas are recommended, not only one. Attached blood pressure monitor, pulse oximeter, and plus or minus ECG monitor, and just keep an AED ready and prepared in case you needed to do a CPR or use the AED. Give oxygen, 15 liters per minute, to maintain peripheral oxygen saturation between 94 and 98, or 88 to 92 in case of hypercapnia. IV fluids, treat the underlying cause if it is detected and known. This is also another summary, which all of in the right side or the left side, all of the things that has been mentioned before, it is here, and the other side, which is the management, also everything was here, but I have added few examples, like in case of opioid overdose, as we said that we may find this by constricted pupil. The antidote or the medication that we may give is naloxone, a dose of 0.4 to 0.8 milligram IM. Most of the clinics, they have the naloxone, and we are working on providing the naloxone in all the clinics. If hypoglycemia is present, we have to start the management of hypoglycemia, and if hyperglycemia, also the same. And we have mentioned those in the last session. The last topic that we will talk about today is meningitis, which happens a lot in pediatrics. Mostly we see it in pediatrics age group. It is whether meningitis or encephalitis are both present in similar fashion, usually rapid onset, within 48 hours. There are typical symptoms may be preceded by a prodrome of fever, vomiting, malaise, poor feeding, and lethargy, which is often indistinguishable from viral infection. So at the beginning, the patient will present with symptoms similar to viral illness, then meningitis will develop and deterioration of symptoms may develop. Particularly significant early signs include severe leg pain, so bad that the child cannot stand or walk and may have limping, cold hands or feet, although the patient is febrile, pale skin, and blueness around the lips, yani cyanosis. Typical symptoms and signs are meningism, headaches, and neck stiffness, cannot put the chin on the chest, and photophobia. Kernick signs may be positive, increased intracranial pressure, causing bulging fontanelle or seen as a bulging fontanelle, especially in infants, drowsiness, decreased level of consciousness, vomiting, irritability, decreased pulse rate, increased blood pressure, fitting, neurological signs, abnormal tone and posturing, all may be seen in case of meningitis. Septicemia and septic shock also may be as a complication. A petechial rash may suggest meningococcal septicemia. or meningococcal meningitis. Small children and immunocompromised patients may present atypically. They may have decreased feeding and irritability alone without seeing other signs or symptoms of meningitis. So we have to call ambulance if you are suspecting meningitis and transfer the patient very fast to the hospital, because they have to start antibiotic as fast as possible by IV route. If shocked, lay the patient flat and raise the legs above the waist height, give oxygen, and gain IV access, large bore cannulas, so they can start the antibiotics right away. We have to give the IV or IM antibiotics immediately while awaiting transfer, but keep in mind that if the transfer received, or the ambulance came and you didn't give the antibiotic yet, just don't delay transfer. Send the patient right away to the emergency room with a proper documentation of the signs and symptoms and the suspicion that you are having. Those are the antibiotic doses according to age of the patient. And thank you very much for your attention. And I hope you are doing well, and I'm ready to answer any question.
لو سمحت دكتورة سارة.
تفضل.
What is meant by the word يعني when I say semi-conscious، يعني ايه بيبقى مقصود بيها ايه؟ semi-conscious ده يعني ليه في السكور مثلا سكور معين؟ أنا بشوف
يعني
أحيانا مثلا مكتوبة
رقم بالضبط ما عندي كم رقم بالضبط، يعني عادل السيمي كونشس عادل كم بالضبط بالجلاسكو كوما سكيل. بس what I can tell you that the Glasgow Coma scale is not 15/15. The patient is conscious، بيسمع وممكن يرد مرة ثانية lose consciousness. He's not fully conscious and not so fully unconscious. يعني مو 3/15 conscious level ولا 15/15. اوكي
تمام. اوكي بالنسبة للديازيبام في الاكسترا بيراميدال احنا بنعطيه عادي في المستوصف IV؟
You can. Yes you can.
بس هو ده السؤال.
اوكي معلش دكتورة سارة، حاجة بره التوبيك بس يعني احنا ليه في الريفيرال سيستم عندنا بيبقى الريفيرال يعني ريستريكتد للهوسبيتال اللي تبع الاريا؟ انا بيجي لي بيشنت كتير في حالة emergency ومحتاجة ريفير على اقرب مستشفى والسيستم مش بيقبل، يعني هل في حكمة من كده؟ يعني ليه ريستريكتد؟
لحظة، شلون أقرب مستشفى مو هي اللي تابعة لها المركز؟
بيجي لي بيشنت مثلا شغال في الجمعية مثلا وبطاقته في مكان على اريا تانية خالص، مثلا أنا حوالي وهو على الفرعونية، فباجي أطبع الريفيرال على مبارك أقرب مستشفى بيرفض.
منو قال؟
السيستم بيرفض يطبع على هو كده.
هالشيء دكتورة آخر مرة؟
نعم أنا حصل معايا قريب هيد تروما لسه الأسبوع اللي قبل اللي فات تقريبا، وكان جاي البيشنت من الجمعية هيد تروما وكان السكور بتاعه تقريبا 14. كان الاي اوبننج للساوند نوت سبونتينيوس، بس كان اورينتد يعني وبي كوماندز وكده. فطلبت له الامبولانس، وطبعا عملت ريفيرال على المفروض ان طبعا جيت اطبع على المبارك اقرب مستشفى ما قبلش. هو اصلا بيطلع لنا كده you can't refer to this hospital.
انا من يومين محاوله مريض هو تبع الفرمانيه، حولته على الامير لانه كان جاينا المركز القادسيه.
عندنا مش عارفه دايما بيطلع لنا ريفيوز. طبعا لما عملته بس على الفرعونيه، فطبعا لما جه الامبولانس قال لي لا يا دكتوره الطريق صعب ولازم على مبارك، فعدلتها مانيوال.
بس
يعني انا عدلتها بايدي.
I will check this because I'm concerned about the emergency committee. I will check this if it is يعني إذا I will make sure about your comment, and if it is يعني accurate and we will not accept this. يعني we will raise this to the higher authority يعني المسؤولين عن هالشيء, and inshallah we will change this because this is not right. An emergency البيشنت جايش راح يروح حق أقرب مستشفى، ما راح يروح حق مستشفى اللي يتابع له. ف you can do it manually until we solve this issue, and I will write it down as a note and we will see this issue أكيد إن شاء الله. Thank you for your comment دكتورة، مشكورة يعطيك العافية.
تسلمي يا دكتورة.
Okay, any other question?
مساء الخير دكتورة سارة.
نور.
الله يعطيك العافية. إيمان مع حضرتك.
الله يسلمك.
دكتورة سارة بعد إذنك، في specific age for hospital referral for cases of convulsion in infancy or in childhood؟ يعني مثلا احنا قلنا في الجروب there is specific age group below it we have to refer it. For convulsion, if the infant is يعني for how many years I can يعني ممكن أقدر أديله التحويل for emergency now.
It has nothing to do with age.
Okay. For
إحنا أول
convulsion,
شيء
not related
febrile
to the
convulsion. What is the age of febrile convulsion? From what age to what age?
from 6 months till it can be for 3-5 years. Yeah.
6 months to 6 years. حفظيها 6 ب6 أسهل لك. 6 months to 6 years. إنزين.
Okay.
إذا جايك ياهل below 6 months وعنده fever وعنده convulsion ما راح تحولينه؟
لا below 6 months I have to refer
تمام
that.
تمام متفقين راح نحوله. إنزين بين 6 months to 6 years عمره 7 months ويايك fever convulsion ما راح تحولينه؟
If it's a first attack, I have to refer. If it's a status, I have to refer. If it's parents, يعني I will take the other indications for referral away from the age.
Yes. Mostly a 7-year-old child this will be his first or her first attack. This child will be referred. يعني حتى اللي febrile convulsion, this is not the first attack, وانت you are not sure, or the parents are not sure, and the parents are so anxious and so panicked because of the seizure, ومثلا السيجر طولت شوية, whatever was the situation, if you refer, this is not wrong. What you have done is completely right. خلي يروح emergency room to be observed like for a few hours, then they can discharge the patient from there.
Okay.
There is no, it's not about the age, it's about the guidelines and your judgment. والguidelines مثل ما قلنا just to guide us. هي مو شيء منزل احنا لازم نمشي عليه بالحذافير, ولكن it's just to guide us, to give us like to ensure safety of the practice and safety of the patient and safety of our practice. So يعني لا نحدد نفسنا بإيه كم العمر اللي لازم, لا, it's not about age, it's about the whole situation, your judgment, and what are the guidelines recommending.
Okay, thank you دكتورة.
Most welcome.
لو سمحت دكتورة سارة.
تفضل دكتور.
دكتور علي معك. بالنسبة لحالات المننجايتس, ايه البروبر انتيبيوتيك اللي اقدر اعطيه في المستوصف قبل ما احول الحالة؟
طبعا هو according to guidelines it's benzalpenicillin as you have seen. احنا ما عندنا البنزالبنسلين عادة في الكلينكس. سيفوتاكزيم اعتقد كان الثاني, شنو اسمه الثاني؟ الدواء الثاني
بس مش متوفر.
هم مش متوفر. يعني احنا ليش حطينا نقطة هذه انه don't delay transfer to the patient even if you don't give the antibiotic is for that reason. If you don't have the proper antibiotic to be given for meningitis, which is يعني شنو chance of having, أنا يعني حطيتها لأن it's one of the things that we may come encounter. بس is it common؟ منو فيكم شاف meningitis يعني وكانت meningitis؟
جتنا حالة من شهر, جتنا حالة في مركز العدنة التخصصي من شهر, صدقت meningitis neck stiffness وتمبريتشر 40.5.
adult ولا pediatrics كان؟
pediatric حوالي 2 years.
تمام. فشنو صار كان السيناريو؟ شلون يعني شنو سويتوا له؟
سوينا نزلنا التمبريتشر بس ما عندنا اي شيء, ولا حتى السيسترات ما عارفين يركبوا اي في كانيولا. وطلبنا له اسعاف وحولته مباركه اسرع من العدن, وقبل الاستمعاد وحولته مستشفى مباركه, يعني مبارك اقرب من العدن.
ممتاز.
ومع ان التخصص كان قبل, يعني العدن التخصصي تبع العدن. صح. مستشفى مبارك اقرب اسرع يعني واقرب. الاسعاف حتى يعني
والله مبارك من العدن اقرب من العدن حق مستوصف العدن التخصصي.
مبارك العدد تخص يعني الاسعاف قال اقرب لي, قال 10 دقائق انا اكون هناك. قلت له خلاص اسرع اوصل بي.
اوكي ممتاز, excellent. But what you have done is proper يعني. If you don't have the antibiotics, the recommended antibiotics, I should search for another options يعني other than those 2 options اللي محطوطين في الجايدلاينز. I should search for it and I will inform you. اعتقد في مرة سؤال وصلكم اعتقد اجابته ان شاء الله, اللي هو مال الهايبوغلايسيميا, صح؟ المفروض انه وصل, انا بعثته.
ايوه يا دكتوره وصل.
ان شاء الله I will search for another options for meningitis antibiotics that is present in the clinic, and I will give you the dose and وحتى انت you try to search it out بعد.
دكتورة بعد إذن حضرتك.
have antibiotic refer the patient right away. أهم شيء قلنا في المننجايتس suspect stabilize and refer.
دكتورة بعد إذن حضرتك، من سن 10 سنين فما فوق هندي فاليوم اي في
حق شنو؟
الكونفالجن. مريض جاي لي بكونفالجن.
ليش تعطينا اي في؟
هدي ده
حتى حق الالدرلي تعطين ركتل. شو المشكله؟ شنو الاسرع؟ عندك اي في لاين give اي في، ما عندك اي في لاين give الركتل. it's fast, it's effective and it doesn't need an IV line. واصلا المريض is seizing, while he's seizing it will be so difficult to connect an IV line. If the nurse is competent and she can do it, well and good. But otherwise شنو the fastest way and fastest and effective way of giving an anticonvulsant is by rectal diazepam, and the dosage is present and available, and it is appropriate from birth lane elderly.
Okay, مشكورة يا دكتور.
Sara, this is Dr. Saima with you.
Yes,
in the patient with TIA, the patient is not on any anticoagulant, not on any warfarin. Can we give aspirin if the patient have asthma?
Of course, most of you now by now know that not every asthmatic patient, the NSAIDs are contraindicated for them, right?
Okay.
So unless this patient, you know that his asthma is induced by non-steroidal anti-inflammatory, you know that this is induced by non-steroidal. In this case, you cannot give the aspirin. Otherwise, in any other patient, you can give the aspirin.
Okay, doctor, thank you.
You're welcome. And by the way, most of the clinics, they have Plavix now. They have one box of Plavix that can be used in case of, like, if you have to give the aspirin and it's contraindicated for any reason, you can give Plavix instead. But usually, aspirin, mostly it can be given safely unless it is one of the three groups that we have mentioned. And if it is contraindicated, like in case of NSAID-induced asthma.
Okay, Dr. Sara, thank you.
Welcome.
دكتورة بعد إذنك، هو في الاستروك إيه المقصود بماينس 1؟ يعني لو في مثلا loss of consciousness ده ضد الاستروك، يعني مقصود بيه كده؟
يعني the possibility of a stroke is lower, so we have to think of any other differential diagnosis. إذا كان only loss of consciousness.
اوكي تمام، شكرا.
I like your questions by the way، وحلوين يعني مبين في تفاعل جميل، فأشكركم. I think
thank you so much, Dr. Sara.
Most welcome.
I think no more questions.
Yeah.
Your lectures are really amazing, very practical.
Thank you.
You're helping a lot. Thank you so much for that.
Thank you so much. Thank you.
And hopefully see you next week.
Inshallah.
Okay.
Okay.
Thank you so much. Good night, everyone. Good night, Doctora.
Thank you, doctor.